So where are we now? Well, this is quite interesting data, and I'm really grateful to Anne-Catherine Brill, who's in the audience, for letting me have these couple of slides. Her paper is in press, and I understand appearing any day in sleep medicine. But this is what happened as a consequence of the Servo-HF safety notice, and would have happened in many of your units as well, in that everyone had to review their practice regarding adaptive servo-ventilation. And of course, that will vary according to your hospital, your referral base, and the types of patients you put on ASV. And this is the experience in Bern. But I think it's extremely interesting. So 120, at the time of the safety notice in 2015, there are 126 patients who were on adaptive servo-ventilation. But they certainly weren't all heart failure patients with systolic heart failure. Substantial number, you can see 40% were on ASV for treatment emergent central sleep apnea, and they had preserved ejection fraction. There were some for co-assistant OSA and CSA, so perhaps CPAP resistant central sleep apnea, and then a number for other reasons, post-stroke, due to medications, and some with cardiovascular disease. But actually, in practice, what this group had to do was withdraw adaptive servo-ventilation from around 10% of their patients, which were patients who mirrored those in Servo-HF who had the adverse effect. So relatively small population of patients. They did, however, have to ensure that the ejection fraction was suitable, so these patients had preserved ejection fraction or greater than 45%, get an updated echo, so there was some funding impact. And of those patients where ASV was discontinued, there was only one adverse effect, which was an emergency hospitalisation for heart failure. But notably, the sleep-disordered breathing, all the patients were reinvestigated, and the central sleep apnea reappeared immediately, and symptoms returned too, and those patients were treated differently. And I think it's only fair for Anne-Catherine at some other session to present how she managed those patients. But this was the consequence in one large centre who were using adaptive servo-ventilation. And there's been some other more recent work, and this is the CAT-HF trial. And this is the use of adaptive servo-ventilation in heart failure patients who are hospitalised with heart failure exacerbation. And so what this group did, with O'Connor being the senior author, is they took hospitalised heart failure patients. And this study differed from Servo-HF in a number of ways. Not only that these were patients who, instead of being steady state heart failure patients, were unstable. They admitted with an acute exacerbation. They had a sleep study, and they were enrolled in the trial if they had an apnea-hypopnea index of more than 15 per hour, but they were allowed, they had obstructive or central or a mixture of sleep-disordered breathing, so they were different in that respect. They were also different in respect to the fact that they had a mixture of patients with systolic heart failure and heart failure with preserved ejection fraction. And the other difference from Servo-HF was, instead of having a fixed level of EEP or positive pressure during expiration, they used the device with variable expiratory positive pressure. And this paper was published, as you can see, just at the turn of the year, early this year. And what did it show? Well, this is the effect on the sleep-disordered breathing, and the patients started on ASV, were monitored, they went home, and they used ASV over the next 6 months. And interesting, you can see this is the effect of this is apnea-hypopnea index, so mixture of events, obstructive central events, significantly reduced, well below 5 in the patients on ASV. But as you might expect, in the control group who had no adaptive servo-ventilation, their cardiac medication, of course, was optimised. As you might expect, there was a fall as they recovered from the exacerbation. There was a fall in the apnea-hypopnea index in recovery, and then a stabilisation at 3 months, and the same level of apnea-hypopnea index at 6 months. And so this came down roughly at 3 months from 35 to around 19, an AHI of 19, but suppressed in the ASV limb. What about the outcomes? Well, this is quite complex, but actually, in reality, straightforward. And what these bars show are the overall results of the study, ASV versus control. The results in the patients with reduced ejection fraction, ASV versus control, and the results in those with preserved ejection fraction, diastolic heart failure, again, ASV versus control. And what the bars mean in the individual colours are light blue is death, purple here is hospitalisation, and then the primary endpoint again was a composite one that included not only death but hospitalisation, but also a functional impact, which was the change in the 6-minute walk. And so the patients in the 6-minute walk either got worse, better, or stayed the same. And so these red, yellow and green bars are the reflection of those outcomes from the 6-minute walk. And the bottom line for the results were similar to Servo-HF. If you compare for the overall patients, so this is the combined group of patients, there was no impact on this primary endpoint, this global composite endpoint on the ASV patients, no reduced deaths, hospitalizations, or change in the 6-minute walk compared to the control group. Again, there was no difference in the reduced ejection fraction patients. But in the diastolic heart failure patients, preserved ejection fraction patients, there was an improvement in the ASV group. And it was largely driven, as part of that composite endpoint, as you can see, by the reduction in hospitalizations. And this was a pre-specified analysis on the difference between the two sorts of heart failure. And you can see here, looking at the hazard ratio, the one group where ASB had a better outcome was the group with the preserved ejection fraction. Now, there are disadvantages to this study that I think we ought to discuss, in the fact that it was in progress at the time that Servo-HF was finishing, and the primary endpoint was calculated with an N number, have sufficient power of 215, but at the time that Servo-HF results were announced and the safety alert came out, the trial was stopped for safety reasons, and at that point 126 patients, as you can see from the original study, 126 patients had been randomised, and so the power of the study to detect the result as intended was reduced. Having said that, there was still a significant difference in outcome in the heart failure with preserved ejection fraction group. And the second pre-specified subgroup analysis they did from CAT-HF was linked to this concern about arrhythmogenesis and the sudden death in the Servo-HF trial, was they analysed arrhythmias in the study. And of course, they could only do that in patients who had implanted cardiac devices that could be interrogated. And so this is how it turned out. Patients either randomised to control or randomised to ASV that had devices which could be downloaded and interrogated, and these were interrogated in a standardised way in a core lab, and then assessed at baseline, 3 months and 6 months. Now, it's also important to say that this sub-study group of patients is predominantly those with heart failure with reduced ejection fraction, because, of course, they are the patients who are most likely to have implanted cardiac devices. And so between 70 and 80% of these patients randomised had systolic heart failure. What did they show? Well, they looked at an index which is familiar to cardiologists and quite probably to many of you, looking at the burden of atrial tachycardia and atrial fibrillation. And that, in simple terms, is the proportion of the time you measure spent in atrial tachycardia or atrial fibrillation. So it's the kind of dose of atrial dysrhythmia that you have. And what they showed was that in the group on ASV, this is baseline, this is 6 months, and this is the control group, there was a reduction in the burden of atrial tachycardia and atrial fibrillation in the ASV patients, and no change in the group in the control group. The problem we have to contend with here is, of course, you couldn't randomise for the degree of the burden in the first place, and it so happened, or you couldn't balance for that at baseline. And so there was more atrial tachycardia and atrial fibrillation in the ASV group, and therefore more potential for reduction. But there was a significant reduction and no significant change in the control group. They also looked at the same index, but this time ventricular tachycardia and VF burden. Again, ASV at 0 and 6 months, and the control group at 0 and 6 months. And there is a small change, but that change in ventricular arrhythmias was not significant. When looked at in more detail, there was no significant difference, whereas the statistics on the atrial fibrillation, atrial tachycardia burden did show a significant improvement. I think it's important to go back to consider the limitations. This was a study that was terminated early and as a consequence had a lower than anticipated sample size and therefore power. The randomization to look at this arrhythmia problem couldn't be stratified. It wasn't on intention by device type. And in this arrhythmia sub-study, the vast majority of patients, as I mentioned, had reduced ejection fraction. But the conclusion, and this sub-study of CAT-HF is still only published in abstract form, and I'm grateful to Adam Benjafield for giving me this data. It will be published in full, but these are the conclusions when it was presented. That there was a significant reduction in atrial arrhythmia burden, but no significant difference, which I think is important, bearing in mind the sudden deaths in Servo-HF, no gain in a ventricular arrhythmias on adaptive Servo-Ventilation, but no reduction either. And so just to summarise the pre-specified subgroup analyses of the CAT-HF study, there was an improvement in this primary combined endpoint of hospitalisation, death and functional change and 6-minute walk in the heart failure patients with preserved ejection fraction. The atrial fibrillation, atrial tachycardia burden was reduced in the group on ASV, and they are the exact numbers, and there was no significant change, no significant impact of ASV on the ventricular dysrhythmia burden. And so in many ways, this raises more questions than answers. It certainly hasn't told us exactly why there were the excess deaths in the Servo-HF study, but is more reassuring, I think, in terms of arrhythmias. But if they didn't die of arrhythmias, what did they die of?